right, good afternoon, everybody, and thank you so much for joining us for the start of our event. This is the COVID-19 Professional Education Quickinar, and we are the ESRD NCC. My name is Matt McDonough. I'm actually going to be your host and moderator, if you will, for today's event. And I wanted to welcome you, be the first one to welcome you to today's event. Let's take a look at our agenda today. And this is what we're going to cover today during the call. First off, we'll give you a little bit of info about what this call is about. If you were on our last week's call, you may already know this information, but we want to cover it again. After that, I will introduce today's speaker, David Arrieta, and talk a little bit about his background. And then we're going to try to leave some time today for questions and answers that you can submit from our chat and our Q&A panels. Now, your chat window should be on your screen. Simply type in your question. Be sure that you select all panelists when you submit your chat questions so that all of us here on this side of the screen can see them. Or your Q&A panel, if you find your WebEx menu, you can open your Q&A panel and submit your questions that way. And like I said, we'll leave a few moments at the end of today's event to hopefully answer as many questions as we can before we wrap up. This is a 30-minute event, so we're going to move a little bit quickly today. So this call is a chance for all of us to hear from stakeholders and experts in the community that have pivoted and adapted to COVID-19. It's been a rapid situation, as you all know. So how have these stakeholders and practices and physicians, et cetera, adapted their techniques and strategies to COVID-19? So we'll talk about those strategies and hopefully provide some real-world examples for facilities to put into use. And again, this is a weekly call, and we hope to bring on varying topics each week that will pique your interest and hopefully keep you coming back for future events. So it does give me great pleasure at this point to introduce David Arrieta. He's worked for more than 20 years as both an administrator and an independent consultant in the healthcare field. He's the Chief Financial and Operating Officer of Nephrology Associates in Nashville, Tennessee, where he's overseen a transition to 100% telehealth office outpatient visits in less than 48 hours. Now today, he'll be talking to us a little bit about operationalizing telehealth in the nephrology practice. It's my pleasure to turn things over to David Arrieta. David?
Thank you, Matt. I appreciate the introduction. And just by way also of introduction, here in the conference room with me, I for Nephrology Associates in Nashville. She was instrumental in helping us implement telehealth within the clinical side of our organization. And I also have Tiffany Jones, who's our Director of Finance, in case there are some billing questions or other related inquiries from all of you. And thank you for taking the time to join us, and hopefully we can answer as many questions that you might have towards the end of the presentation. Next slide, please, Matt. So in deciding to perform telehealth overall, the first bullet point, nephrologists and us as administrators need to mentally shift from telehealth being a noun, meaning something else that somebody else does. In the past, as all of y'all probably know, the reimbursements were not equalized between telehealth and physical visits, and so it caused some issues for nephrologists overall to want to make the transition to telehealth. One thing that we have noticed overall in our implementation into telehealth over the course of the last 3.5 to 4 weeks is that it really requires the entire practice to think differently, not just the physician and not just your billing or not just your administrative folks, but really the entire practice, beginning with your front desk agents or assistants, secretaries that are making those appointments, all the way through how a physician documents. The documentation is very similar, but it does require a couple of tweaks. So you have to wholesale be willing to implement this across your entire practice. When we made the decision to switch to telehealth and to implement it on a wide-scale basis for our overall practice, we made the decision on a Tuesday around noon. By Thursday morning, we had workflows out to all of our staff, and we began to process our first telehealth visits that same Friday. And then the following Monday, we were moving on to having very close to now 100% telehealth visits over the phone or over video communication, and we'll talk about that in a little bit. Overall, also, CMS has eliminated both the originating and distant site limitations within the waivers surrounding telehealth. So as long as these waivers continue, and anecdotally, we feel like the experience that nephrologists have had over the course of the last month would lead CMS and HHS to continue some of those waivers a little bit longer. They're tied to the public health crisis, but because of the overwhelming amount of telehealth that's taking place both in nephrology and many other specialties, we feel like there will be lots of pressure to continue to have some type of waiver or some type of equalization between the reimbursement for a telehealth visit and an in-person visit. But overall, currently, both reimbursements for telehealth or an in-person visit are equal, as probably many of you know. Next slide, Matt. So just to give you some real-world information about our practice, in our practice, beginning the week of March 16th, which was spring break for many folks around the nation, but was also what we call kind of Corona Monday, where you started to see a lot of the social distancing initiatives take place, a lot of the stay-at-home or shelter-in-place orders taking place across the nation. We immediately saw that week a 50% drop in our outpatient visits and a 45% drop in our hospital encounters. So we went from a very, very steady 200 visits plus outpatient visits per day to half of that essentially overnight. We started our telehealth initiative on March 23rd, that Monday officially, and have since then recovered about 75% of our outpatient office volume compared to our pre-pandemic and social distancing initiatives. So again, we had 200 plus on a daily basis through our practice and through all of our physicians and advanced practice providers, and we've been able to recover about 75% of those visits. The recovered 75% is about 175 patients per day that we're processing currently, and 85 of those are being carried out via telehealth. The other 15% we are finding are patients who are not able to download the telehealth app onto their phone or who are in advanced CKD stage process who need more support and really need to see the physician as opposed to a telehealth visit. So we've been able to work around that, and we're very, very close now really to about 90 to 92% being carried out via telehealth. Implementing telehealth will allow your practice to continue providing patient care during the pandemic. But one of the pieces of advice that I would give you is to really start looking at this as your long-term plan for your practice, meaning in our estimation, we feel that after the positive experience that our patients have had and our physicians have had, that overall we're not going to go back to pre-pandemic type of nephrology care where patients are coming in and scheduled to come into our offices. We feel we're going to end up somewhere around a 50-50 split between telehealth and in-person visits. So in making the decision to perform and take on telehealth 3.5 to 4 weeks ago, the immediate decision was about seeing our patients and not seeing that drop in our outpatient office volume. But as we got a little further into it, we realized that it's really going to change and shift our paradigm on how we take care of our patients. Suddenly we're thinking about what do we look like after the public health crisis, what do we look after the pandemic, and if, for example, we go back to a 50-50 split between in-person and telehealth, maybe we need less office space, maybe we need different accommodations for our nurses and our staff and our physicians to carry out these visits. So we're starting to see some of the positive impacts within the practice, and potentially there's other areas that we'll be able to increase our revenues and lower some of our expenditures with our office space as well. Next slide, please. As many of you all know, CMS has relaxed HIPAA requirements during the public health crisis, but your physician's responsibility is still to protect patient privacy, and that has not been eliminated. And so while we recognize the fact that CMS has said during this time there really won't be HIPAA audits and there really won't be a looking back at patient privacy, we still take it rather seriously after years of operating under HIPAA requirements. We're still trying to ensure that we protect our patients' privacy as much as we can. We would like to recommend to all of you that you choose a product that provides end-to-end encryption and also an audio-video mechanism. As probably some of you know, there is a reimbursement if you're only able to do an audio visit where there is no video, but that reimbursement is fairly low compared to being able to see them on the phone and being able to use that system. For ease of use, we also recommend that your current EMR or your PM system's telehealth solution be considered first. Most EMRs in our experience have already a built-in telehealth solution, or they have a preferred partner. That makes it easier for that system to work with your EMR we would suggest that you start with that particular vendor to see if that fits your needs within your practice. Next slide, please. If the solution that is provided by your EMR or your PM system is not what you're looking for, or is not something that you prefer for many different reasons, maybe your EMR is not your best friend, as one example, or you just don't want to go down that route, it's too expensive. Some of the EMR companies have started to load some of the costs onto their telehealth to help drive some of their revenue as well. There's many, many products out in the market that you could use as a standalone telehealth communication system while doing your documentation, your visit, your billing within your current EMR and PM system. As some examples, you could look at products such as Anywhere Care, DoxyMe, BC, On-Call, Healthy. Those are different types of systems. They all work essentially the same. And in the current environment with the public health crisis, many of these telehealth vendors have recognized that practices are jumping into the telehealth stream. Most of them are offering a free introductory period, anywhere from a month to about 3 months is what I've heard. And then after that, there's a per physician per month fee. And so you have to be prepared to calculate that into your costs as well. As a further clarification point, CMS has said that FaceTime and Skype are allowed during the public health crisis. We have shied away from those because they are not as secure. They don't necessarily offer end-to-end encryption, and also, especially for FaceTime, they require for your physician's contact information to be released as part of that communication. So we have chosen to go with a different vendor, a private vendor, so that we have that end-to-end encryption built in. Next slide, please. So what we've seen as we've rolled through this as well is that you and your staff are going to take on the role of what we call retail salespeople. Amanda, in communicating with our staff, called it being salesy with our patients. We have to persuade them to use telehealth, and in some cases, many of these patients have never used phones for healthcare delivery. I read a separate statistic where 89% of those patients who are over 65, or really the population who's over 65, 89% of them have smartphones. Some of them may not be able to use all of the different functions within that smartphone, but there is a smartphone component for most of our patients. They are able to have these communications. Each person who will touch base with your patients in a telehealth environment needs to have a separate workflow. We created a workflow for our front desk, for our schedulers and our appointments, so they knew exactly what to do. We have a separate workflow for our nurses who are triaging patients over the phone, and then we have a completely separate workflow for our physicians as well to ensure that everybody knows exactly what they're supposed to do. I've also told many folks that I spoke with that the workflow doesn't need to be elegant. It doesn't need to be a professionally driven PowerPoint presentation. As long as you're able to communicate with your staff on a click-by-click basis exactly where they need to go, please remember that you're changing years of routine and habits for everyone, so make every workflow as detailed as possible. Another component that we've run into is just the kind of click memorization. Every one of your employees knows almost blindly they can move the mouse around the screen and get very close to where they need to go. So they've memorized all the steps. Your workflows need to reflect that and be able to break some of those habits and create new memorizations for them in order to go to the place that you need them to go to. And an example of us persuading our patients, to give you an example of that and how we approach it, as opposed to giving the patient an option to reschedule, when we call our patients, we'll say something to the effect of, I'm calling you about your appointment on such and such date. I would like to move you to a different date if we're changing their appointment date. Due to the current stay-at-home orders, we'll be conducting this visit via telehealth, where you can see the doctor over the phone safely and comfortably from your home. In order to do this, I will need your cell phone number, which starts the process of helping them download the app. So we don't necessarily give the patient an option to reschedule. We immediately jump into, we're doing telehealth because of the public health crisis. Please help us move through that process. We have found that to be far more effective than giving our patients the options. Almost always, if you give the patient the option, they're going to choose to reschedule to a later date. Next slide, please. And please remember that after you spend time writing and distributing your workflow, you need to assume that only about 20% of your staff will actually read them. You send them out via email because that's the most effective way to get information quickly out into your staff. They tell you over the phone that they've read the workflow, and then 20 minutes later they'll call you and they'll ask you a question that is on the very first page of the workflow. You just have to have some patience in being able to move through that with your staff and knowing anecdotally from us that only about 20% of your staff are actually going to read it. That includes the physicians as well. They just assume that they can jump on or that somebody will help them through it. And so just be cognizant of the fact that nobody's really reading your workflows with the exception of 2 out of 10 folks. We would also suggest that you establish a telehealth support center that's staffed by your workflow experts. So those individuals that know your workflow, know exactly how things are supposed to move through the system, those should be the individuals who are staffing your telehealth support center that has quick access for everybody to be able to communicate with those individuals. I would also recommend that your telehealth support center not only be knowledgeable, but also have the ability to carry out some expenses on behalf of the organization. If somebody needs a new laptop, a new computer, that you give those individuals that ability. Next slide, please. Telehealth is also, as you all know, being used on a large scale for outpatient office and dialysis rounding. All of us as administrators and physicians within private nephrology practices can control our offices, but you'll need to adjust your dialysis rounding to the requirements put in place by the dialysis organization that you work with. We strongly recommend that regardless of whatever processes the dialysis organization sets up, that you use your relationship with that local clinic staff, with the charge nurse, clinical managers, in order to facilitate that. A lot of the protocols written for the dialysis organizations are written by folks outside of the facilities. Use your friends within the facilities in order to help you facilitate using their telehealth system. Next slide, please. Developing billing workflows, ensure that your billing department is aware that telehealth is taking place within your practice. We have talked with various practices where the billing folks had no idea telehealth was being carried out. And so please make sure that your billing and finance directors are aware of what's happening on the clinical side. Your billing department has to be able to differentiate between an in-person office visit or a telehealth visit. Please remember that documentation is the same for an in-person or telehealth visit from a provider perspective, but a patient must also consent for telehealth to take place. Consent must be documented in the patient's medical record, and the medical record documentation must identify it as a telehealth visit. So somewhere in your provider or your physician's documentation, it must reflect that there's a telehealth visit taking place and that the patient consented. It's your practice's decision to waive co-pays for telehealth visits, but I would run that through your billing folks, your finance folks, to ensure that you're not breaking any insurance contract models or co-pays within your insurance contract so that you don't violate the terms of your insurance contract by waiving co-pays. Next slide, please. And this is our final slide, but overall, you're significantly altering your practice pattern for your patients, physicians, and your advanced practice providers and staff. Please be patient with everybody. We have found that patience is the best thing that we have had over the course of changing habits. Prepare to answer questions that you've covered in your workflow. First, the physicians will tell you that telehealth has no place in nephrology, and the next day after they do their first telehealth visits, they'll come back to you and say, why didn't we start this a long time ago? So be patient with them as well. And after the public health crisis, we certainly believe that telehealth will have a place in nephrology practices long term. Be patient, proactive, and prepare for the fact that you will have telehealth on a long-term basis even after the public health crisis. And Matt, that's what I have as far as the presentation. I'm free to take any questions.
Great, David. Thank you so much, and to your team that's there as well. Thank you for providing this information today. We have received a few questions through our chat panel. Before we get to a couple of those, I do want to take this opportunity to remind folks that if you are online and you do have a question for our presenters in the room there, you can submit them via the chat panel. We do have, looks like we're going to have about 7 or 8 minutes today to answer questions. So, David, I'll just start asking questions, and and we'll just go from there. First question we got was, you talked a little bit about the predicted increase in the adoption of telehealth as a standard. Are there any patient experience of care or quality of telehealth visit metrics or feedback that your systems or you know of that are currently collected that might reinforce the proof that would be something we're expecting down the road?
Sure, and great question. And what we have found with 3 or 4 telehealth vendors that we have found is that they've never really been asked for metrics in the past. They're very, very focused on the communication method and medium and making sure that it's encrypted. When we went back even to our vendor and said we need some metrics on this in order to continue to invest on the technology side, they really sort of were at a standstill for being able to provide us metrics. So lots of the information right now is number of telehealth connections, length of call, those types of metrics. What we have found anecdotally from our physicians and on a daily basis, Amanda and I, who have staffed the Telehealth Support Center, as well as Tiffany, we get almost a constant barrage of feedback from our physicians and our APPs saying, I love this. We should have done this a long time ago. It's fantastic. So we feel that because of that experience, and we have had many, many comments from our patients, positive comments, they really like not having to leave their home. We feel that it's going to be long-term. But as far as metrics, there's not a lot around that from the telehealth companies. We can start collecting some of that manually, but we haven't done that as of yet.
Very good, thank you. And as someone who uses telehealth frequently, in fact, I have an appointment for my son tomorrow, I can attest that it is a very, I dare to say, enjoyable way to meet with your physician. Another question, or actually 2 came in and they're right around the same topic, so I will ask one of them. For patients that can't load the program on their phone or their computer, have you considered or do you know anyone that's using the dialysis facility as the originating facility, such as maybe providing an iPad to the patient when they're in the facility to help to ease this potential obstacle?
Sure, and thank you for the question. We have thought about it. Our concern has been with the dialysis staff. We are concerned with using their bandwidth and their ability to take care of the patients and be able to move that iPad for what would be a patient or a practice visit as opposed to an ESRD or an MCP visit. We're very cognizant of the fact that they're tied up, that they're going through umpteen number of protocols and policies that are new to them. So we have not gone in that direction because we haven't wanted to tie up the dialysis staff with our practice visits. So we have allowed them to concentrate on dialysis. We do carry out some MCP visits via telehealth using their iPads and using their technology. But as far as carrying out office visits, we have not, again, just not to use up the clinician's time for our practice purposes.
So in your particular practice in this iteration of telehealth, do the social workers and dietitians and others have the opportunity to consult as well with the patient, or is it primarily the physician?
It's primarily the physician, but it is open via waivers to all members of the interdisciplinary team within the dialysis unit. So anybody can communicate with the patient via telehealth, and it is a viable way to communicate and an acceptable way to communicate currently. We have lots of experience with Fresenius, and they're using Microsoft Teams. They've opened it up to every member of the IDT team in making sure that all of those individuals can connect with the patients.
Very good, sir. Thank you. We got about 2 or 3 more. So this one is, are you also using other non-face-to-face visits, like e-visits or phone visits or virtual check-ins, chronic care management where it's allowed, principal care management where it's allowed, or remote patient monitoring?
Yes, we have considered all of them. The remote patient monitoring, we are not quite there yet from a technology basis to have all of that equipment with our patients. That's the next iteration for us with telehealth, is making sure that we do that. On the virtual check-ins, we have looked at that. To be honest with everybody on the phone, we've limited that down to very, very select physicians and very select patients. The reason for that is that just kind of human nature. If we give our physicians and our staff an easier way to communicate with our patients, they will not necessarily try to shoot for the telehealth visit. They'll go for the 5-minute virtual check-in, and they'll say that's all I can do, and they won't extend themselves to really try to push and persuade that patient to do telehealth. So we have maybe 2 or 3 out of our 30 physicians who are allowed, quote unquote, to do a virtual check-in. We know that they exist, we know that they're out there, but only in very, very rural communities and where we trust the physician and the staff not to take advantage of being able to do a 5-minute visit instead of a 20 to 30-minute visit. Those are the only places that we look at. We also look at that from a financial perspective. The virtual check-in reimburses at $13 or $14 per visit after the copay requirement versus what you would get on a full E&M visit. And so we're cognizant of that as well. I would rather push our staff and our physicians to carry out a full telehealth visit.
Very good. That makes very good sense. This one is, we have a lot of different types of questions coming in. This one's a particularly technical question, but interesting to ask is, have you found any particular telehealth platform that uses lower bandwidth? And the reason they're asking this is for very rural patients who seem to have low bandwidth connections or spotty connections and really can't use anything but FaceTime.
Sure, and good question. We did lots of research on the bandwidth carriage through our IT manager here. Each of those phone calls carries about a 1.5 megabyte bandwidth requirement. So if you have 10 or 15 calls taking place all at the same time out of the same site using wireless technology, you may have issues in being able to push all those calls through. So you start to develop some drop calls or blank screens or a couple of the other things. In those scenarios, those are the scenarios where we've chosen to go to virtual check-ins, because just about every telehealth company that we've researched uses between 1.5 to about 2.2 megabyte carriage on the bandwidth. And so you can't get much lower than 1.5, and just depending on how much traffic you have at any given point in time. So in the rural areas, those are the 2 or 3 physicians that we talked about that are allowed to do virtual check-in. And if you think about the technology to get 2 people on the phone, a physician and the patient together, there's lots of variables there. And unfortunately, we as physicians or we as a physician practice don't control all the variables such as Wi-Fi connectivity, the bandwidth that that individual user, the patient, has going into their home. So lots of variables, but that's where we go to a virtual check-in.
Very good. Yeah, and there's some things you just can't control, we understand, and that's one of them. David and team, we're rolling up on 5:28 here, and we've only got a couple minutes left. So for everyone who submitted questions, thank you so much. And thank you, David, for taking the time to meet with us today and to answer all these questions from our attendees today.
Absolutely. And Matt, please feel free to distribute my contact information, and I'm more than happy to jump on the phone or via email and answer any questions.
Wonderful. I will certainly do that. Thank you. Before we say goodbye today, we do want to talk a little bit about our next COVID-19 awareness events. Our next professional call is 1 week from today at 5 p.m. Eastern Time, same time, where we'll be talking with Suzanne Watnick and Liz McNamara from Northwest Kidney Centers. If you're interested in attending that, we'll have more information on the specifics of that event, but if you're interested in checking that out, our COVID registration page is right there. It's esrdncc.org/en/quickinars. And please visit that page to see all of our upcoming professional and patient-focused events as well. So before we say goodbye, we just want to share our contact information with you. If you do have any additional questions for us or for David, please do feel free to email them to us, and we will put you in contact with our speakers, or if we can answer them ourselves, we will. There are additional COVID-19 resources on the screen that you can see from the Kidney Community Emergency Response Program or from the CDC, and we invite you to go out and check those out as well. Again, thank you for joining us for today, for today's call, and we hope to see you in 1 week for our next professional-focused Quickinar. Have a great evening.